Welcome to our deep dive into the world of severe ulcerative colitis, or UC for short.
Yes.
We're using the latest UpToDate resource.
Okay.
It was updated December 2023, so we know we're working with the most current information.
Excellent.
And this is serious stuff, so let's get right to it.
Absolutely.
Yeah.
It's not just, a bad stomach ache.
Right.
Severe UC is potentially life-threatening,
Ah.
and understanding why is crucial for patients.
I think a lot of people hear colitis and they think, oh, it's just a digestive issue, but we're talking about a whole other level here.
A whole other level.
Right.
Yeah. UC involves chronic inflammation,
Okay.
specifically in the lining of your large intestine,
Oh.
almost always starting in the rectum. But severe UC goes way beyond just discomfort. It's about your body really struggling.
So what are the red flags that tell doctors, okay, this is severe, we need to act fast?
So think 6 or more bloody bowel movements every day.
Oh, wow.
And then on top of that, at least one of these: fever over 37.8 Celsius, rapid heart rate, anemia, or signs of serious inflammation in your blood work.
6 bloody bowel movements a day. I can only imagine how debilitating and scary that must feel.
Absolutely.
And to have those other symptoms on top of it.
Yeah. It's a clear sign that the inflammation is out of control and affecting your entire system.
Okay.
And at the extreme end, there's fulminant UC, which is 10 or more bloody bowel movements per day, plus all those other severe symptoms.
That sounds absolutely terrifying. So I'm guessing at that point, you're heading straight to the hospital.
Yeah, a hospital evaluation is essential for anyone with suspected severe UC.
Right.
It's not just about confirming the diagnosis.
Right.
It's about ruling out other problems and figuring out just how bad the situation is.
So walk me through this evaluation. What can someone expect when they arrive at the hospital?
So it starts with blood tests, but they're looking for more than just anemia. They'll check your blood for signs of how well your body is handling this intense inflammation. Things like your cholesterol, albumin levels, and something called C-reactive protein, or CRP.
CRP. That rings a bell. Isn't that a general marker for inflammation in the body?
Exactly. It's become the standard for measuring inflammation, largely replacing the older secrete-make test. These tests help doctors get a clearer picture of your overall health and how much stress your body is under.
So it's like taking the inflammation's temperature,
Yeah.
seeing how widespread the fire is?
Exactly. Good way to put it.
Yep.
Then come the stool tests, and they'll do several.
Right.
In severe UC, your gut is incredibly vulnerable, so they need to rule out any infections that could be making things worse. One major worry is C. diff,
Yeah.
a bacteria that can be really dangerous in this situation.
C. diff. I know that can be a serious issue, even in people without UC.
Exactly.
Yeah.
And they'll check for other common bacteria and parasites, especially if you've traveled recently. They're leaving no stone unturned.
Okay, so we've got the blood tests, the stool tests. Are we done yet?
Almost. You'll likely need a limited endoscopy, which means using a scope to look inside your colon.
Okay.
But they won't do a full colonoscopy.
Why not? Isn't it important to see the whole picture?
In severe UC, a full colonoscopy is actually too risky.
Okay.
The colon is so inflamed that there's a chance the scope could perforate it,
Oh, wow.
which is a very serious complication. So they'll do a sigmoidoscopy, which only looks at the lower part of your colon.
So it's a trade-off. Less information, but a safer procedure. Tough call.
It is. But remember, at this point, the main goals are to stabilize you and make sure there are no immediate threats. That's where the inpatient treatment comes in.
Okay, so you're officially admitted to the hospital. What happens next?
Well, this isn't just about pills and waiting it out.
Right.
Severe UC often requires a multidisciplinary team approach.
Okay.
You'll have a gastroenterologist, a surgeon, and possibly even critical care specialists all working together.
It's incredible how much goes into caring for someone this sick.
It is.
Yeah. It must feel like a whirlwind for the patient.
Absolutely. And one of the first things they'll do is start constant monitoring.
Okay.
They'll be checking your vital signs regularly, doing physical exams, and even tracking your stool output to make sure you're stable and responding to treatment.
I can imagine that tracking stool output might not be the most pleasant part of the process.
No,
But it makes sense. They need to see if things are improving.
absolutely. They'll also start you on IV fluids and electrolytes,
Okay.
which is about more than just staying hydrated. It's about correcting any imbalances caused by the severe inflammation and diarrhea.
So it's like giving your body the resources it needs to fight back.
Exactly.
What else are they watching out for at this stage?
Blood clots are a big concern. UC itself increases your risk, and being hospitalized makes it even higher.
Oh, wow.
So you'll automatically be given medication to prevent them.
Good to know they're being proactive about that. What about food? I'm picturing a very bland, restricted diet.
Actually, if you can eat a regular diet is best. Resting the bowel doesn't actually help the disease itself.
Mm.
But if you're in too much pain or can't eat, they might give you parenteral nutrition, which is basically feeding you through an IV.
That's surprising. I always thought a bland diet was the way to go with any kind of digestive issue.
It's a common misconception.
Yeah.
And sometimes blood transfusions might be necessary.
Yeah.
If your hemoglobin level drops too low,
Yeah.
it means you don't have enough red blood cells to carry oxygen throughout your body, which can lead to all sorts of problems.
Okay. So we've covered monitoring fluids, preventing blood clots, nutrition, and even blood transfusions.
Yep.
It's a lot to take in.
It is. And we haven't even touched on medications yet,
Right.
which is where things get really interesting.
Let's face it, medication is what everyone's really thinking about.
Absolutely.
So what are we dealing with here? Let's save that for part 2 of our deep dive. Welcome back to our deep dive into severe ulcerative colitis.
We've talked about the seriousness of this condition and what to expect when you're hospitalized. So now, let's get to the medications.
This is where it feels like we're entering a whole new level of complexity.
You're not wrong. There are specific medications that are absolutely avoided in severe UC, and it's crucial to understand why.
Okay, so let's start with what not to take, what's on the no-go list.
First up, we have antimotility drugs,
Okay.
opioids, and anticholinergics.
You mentioned avoiding opioids,
Yeah,
but what about pain control?
right.
Severe UC hurts.
It does.
Are you just telling people to tough it out?
Definitely not. It's about choosing the right pain relief.
Okay.
These specific medications can actually worsen a serious complication called toxic megacolon.
Toxic megacolon, we've mentioned that a few times. Can you
Yeah.
explain what it is?
It's when your colon gets so inflamed that it can actually stop working properly,
Oh, wow.
which is life-threatening. These medications we're talking about can increase that risk.
Yeah.
So they're off the table.
Okay, so avoiding those is about preventing things from getting even worse. What else should be avoided?
Oral 5-ASA drugs. They're commonly used for UC,
Right.
but they're pretty much useless in this severe state.
Really?
And surprisingly, even everyday painkillers like ibuprofen are a no-go.
Really? I thought ibuprofen was pretty harmless.
Not in this case.
Mm-hmm.
NSAIDs like ibuprofen can actually trigger flares of UC.
Oh, wow.
So they're definitely out.
So we've covered what to avoid. Let's talk about the medications that do help. What are the go-to treatments for severe UC?
The first-line treatment is intravenous glucocorticoids, usually methylprednisolone.
Intravenous. So
Yeah.
we're not talking about just popping a pill.
Right. In severe UC, you need the medication to work quickly. And the intravenous route delivers it directly into your bloodstream for a much faster response.
Yeah.
We're trying to get ahead of that runaway inflammation.
So it's like a targeted attack.
Yes.
Hitting the inflammation hard and fast.
Exactly. Along with IV steroids, you might also get topical glucocorticoids, like enemas or foams.
So 2 different approaches to getting those steroids where they need to be.
Yes. But it's important to understand that the topical ones mainly help with symptoms like urgency and pain, not the disease itself.
So it's about managing those immediate, really uncomfortable symptoms while the IV steroids work on the bigger problem.
Exactly.
But what if, even with the IV steroids, things aren't getting better?
That's when things get really serious. If after about 5 days there's no improvement, it's time to consider escalating the treatment.
I can imagine that's a really scary moment for the patient. You're hoping that first treatment will be the answer when it's not.
It's a huge blow, but it's not the end of the road. If steroids aren't enough, doctors will often turn to either infliximab or cyclosporine.
Okay, so steroids aren't cutting it. That's a tough spot to be in. You mentioned infliximab as an option. What makes it different?
Infliximab is a biologic drug, which means it targets a very specific pathway in the immune system. Instead of broadly suppressing the immune response, it goes after the specific mechanisms driving the inflammation in UC.
So it's more like a guided missile,
Yes.
going after the root of the problem.
Exactly. It's given through infusions, and you can often see a response within 3 to 5 days.
That sounds promising. What happens if there's no response to that first dose?
They'll typically give you a second dose at a higher concentration and then go back to the standard dose if you respond.
And if you do respond well, what happens then?
Then you'll likely continue taking infliximab as a maintenance therapy to keep the inflammation under control long term. It becomes part of your ongoing UC management.
Okay, so that's one pathway. What about cyclosporine? How does that work?
Cyclosporine is another intravenous drug that works very quickly, but it comes with a lot of potential side effects, so it's not for
So
everyone.
who can't take it?
People with certain pre-existing conditions,
Yeah.
like high blood pressure, kidney problems, a history of seizures, even things like low cholesterol, magnesium, or albumin levels, the
Yep.
list is pretty extensive.
Wow, that's a lot of exclusions. So it's a powerful drug, but it comes with some serious baggage.
It does. And because of those side effects, you need constant monitoring while you're on it. They need to make sure it's helping more than it's hurting.
I'm seeing a theme here. Severe UC requires serious, closely monitored treatment.
Absolutely. And the goal with cyclosporine is to use it as a bridge to a thiopurine drug like azathioprine.
Why this combination? What's the logic there?
Thiopurines work more slowly,
Okay,
so you need something fast-acting like cyclosporine to get the inflammation under control while the thiocurine kicks in.
yeah.
Then, if all goes well, you can slowly wean off the cyclosporine.
So it's a two-pronged approach.
Yeah,
You hit it hard and fast with cyclosporine, and then the thiopurine comes in for the long game.
exactly. But even with these powerful medications, sometimes surgery becomes unavoidable.
I know that's a big fear for a lot of people with UC.
It is.
When does surgery become necessary?
Usually it's if there's no response to medications or if life-threatening complications develop.
Like what are those worst case scenarios we're talking about?
Things like perforation of the colon,
Mm.
which is essentially a hole in the colon wall,
Oh gosh.
or toxic megacolon, where the colon becomes severely dilated and dysfunctional.
Those sound terrifying. And I'm guessing those are the situations where surgery becomes an emergency.
They absolutely can be.
Right.
In those cases, the most common surgery is a total colectomy with endoileostomy.
Can you break down what that actually involves?
In simple terms, it involves removing the entire colon and creating an opening in the abdominal wall called an ileostomy. The end of the small intestine, called the ileum, is brought to the surface of the skin to create this opening, and waste is collected in an external pouch.
Wow, that's major surgery. I'm sure we could do a whole separate deep dive on that alone.
Definitely. It's a big topic with a lot of nuances. But for now, let's stay focused on severe UC and those escalating treatment options.
Okay. So we've talked about steroids, infliximab, and cyclosporine. What happens if someone has fulminant UC, that most severe form we talked about earlier?
Well, in that case, everything we've discussed becomes more urgent. You'll be monitored even more closely, treatments will be escalated more quickly, and the threshold for considering surgery is much lower.
How much lower are we talking?
Instead of waiting 5 days to see if medications are working, they might consider surgery after just 3 days of no response.
So it becomes a race against time to get that inflammation under control.
It really does. And then there's toxic megacolon, which, as we mentioned, is another life-threatening complication.
Okay. I'm definitely getting the sense that toxic megacolon deserves its own episode. We'll put that on the list. But for now, let's say someone has gone through the hospital treatment, and thankfully they're starting to improve. What happens when they're ready to go home?
That's a great question. It's a relief to reach that stage, and the goal is to make sure you're stable and on the right track for recovery before you head home.
So it's not just about feeling better, it's about making sure your body is truly recovering before you go home. That's reassuring. What are the criteria for discharge? What boxes need to be checked?
First, your vital signs need to be normal. No more fever, rapid heart rate, or low blood pressure. You should have fewer than 6 bowel movements a day with little or no blood,
Okay.
no more severe pain, and you need to be able to eat normally.
Okay. That sounds like a pretty thorough checklist. What about medications? Are you still on the same regimen as you were in the hospital?
That's where things can get a bit tricky again. If you are on intravenous glucocorticoids, they'll switch you to oral prednisone before you leave the hospital.
So you're stepping down from the IV meds, but you're not off steroids completely.
Correct.
Do you stay on prednisone long term?
Ideally, no.
Mm-hmm.
Steroids can have some pretty nasty side effects if you take them for too long, so they'll start tapering you off as soon as possible.
Okay. Why the slow taper? Can't you just stop them cold turkey?
That can be dangerous because your body can become dependent on steroids.
Ah.
Suddenly stopping them can send your system into shock and could even trigger a severe flare-up of your UC.
Oh, wow.
So it's a gradual reduction to give your body time to adjust.
So we've talked about stepping down from the IV steroids to oral prednisone and then slowly tapering off. What about those other medications we discussed, like infliximab and cyclosporine?
That all depends on what worked for you in the hospital and what your doctor recommends for your long-term management plan. Every case is different, and there's no one-size-fits-all approach.
It sounds like a lot of careful consideration and decision-making goes into this process.
It absolutely does. The ultimate goal is remission. And remember, remission doesn't just mean you're symptom-free. It also means your colon is healing.
So how do you know if your colon is actually healing?
And that's where a colonoscopy comes in. They'll usually schedule one 6 to 12 months after you achieve remission to check on how things are progressing.
Ah, the dreaded colonoscopy.
Yes.
But at least it's not as frequent as during those acute flare-ups. So you're physically recovering. But what about the emotional toll? Severe UC can be scary. How do you support someone going through that?
That's such an important point. We focus a lot on the physical aspects of this disease, but the emotional impact is huge.
Yeah.
Having a strong support system is essential. Talking to loved ones, joining support groups, even seeking professional therapy can all be incredibly helpful.
Yeah.
It's about acknowledging that this is a tough journey and you don't have to go through it alone.
That's a really important message. Severe UC affects your whole life, not just your physical health.
Absolutely. And while we've covered a lot of ground here, we've only scratched the surface of what it takes to live with UC long term.
Okay. So we've tackled the scary stuff.
We have.
The hospital, the medications, even surgery. Let's shift gears in part 3 and talk about what comes next.
Okay.
How do you stay well and manage UC long term?
Welcome back to the deep dive. We've covered the kind of intense world of severe UC diagnosis and treatment, but now, thankfully, we're focusing on the brighter side, long-term management.
Yeah, that's right. We're shifting gears from crisis mode to what it takes to stay well and hopefully prevent those flare-ups from happening again.
That's the dream, isn't it? So where do we even begin with long-term UC management? Well, the first thing to understand is that the approach is personalized,
Okay.
based on what worked for you during that initial hospital stay.
Right.
It's about figuring out which treatments helped you the most,
Uh-huh.
and then using that information to create a plan for the long haul.
Okay, so let's say you were fortunate enough to respond well to steroids alone.
Right.
Without needing those heavier hitters like infliximab or cyclosporin, what's the next step?
In that case, your doctor might recommend an anti-TNF drug like infliximab as a maintenance therapy.
Okay.
Sometimes they'll add a thiopurine, like azathioprine, to the mix for a while.
Uh-huh.
But the goal is to prevent the inflammation from coming back with a vengeance.
So even though steroids help you get out of that acute crisis, they're not the ideal solution for the long term.
Exactly. They're great for short-term control, but the long-term side effects can be a real concern. It's about finding the right balance between effectiveness and safety.
Makes sense. What if steroids weren't enough? But infliximab was the key to getting things under control.
If infliximab was your hero, you'll likely stay on it for maintenance. They might add a thiopurine for a period of time, but then taper you off, leaving you on infliximab alone. It becomes your long-term partner in keeping the inflammation at bay.
So you found what works and you stick with it. But earlier you mentioned a special consideration for young men.
Right.
Can you explain that a bit more?
Yeah. For young men under 30, they usually stay on infliximab alone, even if they initially needed a thiopurine to get things under control. This is due to a very slight risk of a rare type of cancer associated with the combination of infliximab and thiopurines.
Oh, wow.
It's incredibly rare, but the potential consequences are serious enough that doctors err on the side of caution in this specific group.
It's good to be aware of that. We'll make sure to include some resources in the show notes for anyone who wants to learn more about that specific risk. So we've talked about scenarios where steroids worked and scenarios where infliximab worked. What if cyclosporin was the lifesaver?
If cyclosporine was the medication that turned things around, you'll typically switch to the oral form of the medication.
Okay.
You'll also be put on a thiopurine and start tapering off the steroids.
So again, it's about transitioning away from those strong, fast-acting medications that come with more risks to something more sustainable for the long term.
Right. And once the steroid taper is complete, they'll slowly reduce the cyclosporine until you're off it entirely. Hopefully with the thiopurine keeping you in remission. It's like a relay race, with each medication playing its part at the right time.
And what if the thiopurine isn't enough on its own? Is it back to square one?
Not necessarily. There are other medications they can try, and each case is really individualized. But sometimes surgery does become the best option, even after trying various medications.
So it's a journey with different paths, and you might have to adjust the route along the way. But let's talk about what it means to be in remission. You mentioned earlier that it's more than just feeling better.
Absolutely. Remission is the ultimate goal, and it means two things. First, your symptoms are gone.
Okay.
And second, a colonoscopy shows that your colon is actually healing.
So it's about both the internal and external signs of recovery. And how often do you need a colonoscopy once you're in remission?
Usually they'll do one 6 to 12 months after you achieve remission,
Okay.
and then the frequency will depend on your individual case and risk factors. But thankfully, they're not as frequent as during those acute flare-ups.
That's good news. So much of what we've talked about so far focuses on the medical side of things, medications, procedures, hospital stays. But I imagine lifestyle plays a huge role in managing UC long term as well.
You're absolutely right. It's not just about what your doctor does. It's about how you take care of yourself day to day.
Right.
And diet is a big one.
Okay.
Working with a registered dietitian to find a personalized eating plan that helps you identify and manage your triggers can make a world of difference.
Yeah.
It's not about following some restrictive one-size-fits-all diet. It's about figuring out what works for your body.
So it's about tuning into your body signals and making adjustments as needed. Are there other lifestyle factors that can help?
Absolutely. Stress is a huge trigger for many people with UC.
Yeah.
We all know that stress can wreak havoc on our bodies, and the gut is definitely no exception. So finding healthy ways to cope with stress, whether it's exercise, meditation, spending time in nature, or talking to a therapist, can be incredibly beneficial.
It sounds like a holistic approach to managing UC. It's about taking care of your mental and emotional well-being, not just the physical symptoms.
Exactly. And the good news is that research on UC treatment is constantly evolving. There are always new medications and therapies being developed, so there's always hope for even better options on the horizon.
That's encouraging. So to wrap things up, what are the key takeaways you want our listeners to remember about long-term UC management?
I think the most important message is that severe UC is challenging, but it's manageable. With the right treatment, ongoing care, and a proactive approach to lifestyle, you can live a full and meaningful life. It might feel overwhelming at times, but there's a whole community of healthcare professionals, support groups, and others who are there to help you every step of the way. You are not alone in this journey.
That's such a powerful message, and I think it's important to emphasize that knowledge is power. The more you understand about UC, the more equipped you'll be to advocate for yourself and make informed decisions about your care.
Couldn't agree more. It's about being an active participant in your healthcare journey, not just a passive recipient of treatment.
Well said. Thank you so much for guiding us through this deep dive into the world of severe ulcerative colitis. It's been an incredibly informative and, dare I say, hopeful conversation.
It's been my pleasure. And remember, this is just the beginning of your journey of understanding. There are many resources available to help you learn more and find the support you need. We'll be sure to include links to UpToDate's patient information and other helpful organizations in the show notes.
Until next time, stay curious, stay informed, and keep on learning.